It's my great pleasure to introduce Dr. Mahado-Chang. She's a good friend and also a movement disorder specialist trained at Mount Sinai Medical Center in New York. In fact, she just told me she did all of her training there, so medical school, residency, and fellowship training, and now actually works at UC Davis and sees quite a few patients with Parkinson's disease. And she's here to speak to the more medical and sort of recent medical advances when it comes to treatment of Parkinson's disease. So, Dr. Mahado-Chang.
Thank you to all of you for coming. I'm very excited to be here. I'm also very excited to see so many familiar faces. It's kind of like a clinic reunion here. I love it. So I have some good news and bad news. The good news is that we have a lot of advancements to talk about when it comes to Parkinson's disease. Medical advancements, surgical advancements, stem cells. But the bad news is I'm going to try and cover as much of it as possible, which means that you'll be hearing me up here for a while. Please, if you need to, I won't take it personally if you need to get up and take a stretch, because there is a lot to discuss, and it's very exciting. I hope ultimately that I have this opportunity to share my excitement and my enthusiasm with you, because this is really, really a very hopeful time for Parkinson's disease. Okay, so the way I've divided the talk is into 4 parts. I think this kind of tries to make things a little bit more clear. There's advancements in the field of diagnosis. We have to know what we're dealing with, right? So we have improvements in our ability to diagnose idiopathic Parkinson's disease, and we also have improvements in terms of recognizing and treating all the non-motor symptoms. And then we have improvements and advancements in therapies. I've divided the therapies for the purposes of this talk into non-invasive therapies and invasive therapies. So non-invasive, in that category, I put oral and transdermal medications, exercise and diet, which you've already heard quite a lot about. Thank you. And then as far as invasive therapies go, we have lots to discuss with regard to deep brain stimulation, also known as DBS, duodopa, apomorphine, and stem cells. Finally, I think there's a lot of advancements in the realm of support and resources. There's so much more support. I mean, just even looking out at the sea of you, 500 people who've all here together, and there's a camaraderie, there's a huge amount of support that wasn't present years ago. So I think that's very important. I'll also share with you some resources that I think can be very helpful, not only for patients, but for families and caregivers as well. So we'll start off and we'll talk about some of the advancements we have in terms of diagnostic accuracy. It turns out that Parkinson's is really not just one disease. We have a lot of different diseases that fall under the realm of Parkinsonism, and it's very important to be able to differentiate these because some diagnoses that we previously confused with Parkinson's turn out to have very different pathophysiology and different disease courses. Some of these, they all have very complicated names, but some of these go under the names like progressive supranuclear palsy, multiple system atrophy, cortical basal ganglionic degeneration, Lewy body disease, and vascular Parkinsonism. Dr. Thacker introduced the concept of DAT scan. I will emphasize that all of these conditions, the atypical forms of Parkinsonism as well as idiopathic Parkinson's disease, are all made clinically. That is, with an expert examination in the office, we can make this diagnosis. However, the dopamine transporter scan, also known as DAT scan, can be very helpful when the diagnosis is a little complicated or less clear. The FDA approved the DAT scan technology in 2011 for the United States, and it involves the injection of a radiopharmaceutical agent into the veins of a patient, and we look for abnormalities in the brain's dopamine transporter. So it's different than a test, for example, like an MRI of the brain, which is an anatomical study. just looking at the structure. This is actually a functional test that is looking at the function of the dopamine transporter. So it's helpful in that way. The problem is that it's open to interpretation, and these scans can often be misread. So it's still not a substitute for the clinical exam. Here's an example of what a DAT scan might look like. On the left-hand side, you see an image that is a normal scan. You'll see the typical comma shapes of the basal ganglia. This happens to be a patient who has essential tremor. So it's a tremor, but it is not the tremor of Parkinson's disease. Sometimes that can be confused. On the right-hand side is an abnormal scan. As you can see, the comma turns into what they call more of a period shape, and more so on this patient's left side, your visual right side of the scan, which has significantly decreased dopamine transporter activity. Okay, so if any of you saw the KVIE program, or my patients know very well that I refer to the concept of the iceberg to represent Parkinson's quite a lot. And I use this metaphor because I think it's very fitting, and it helps to visualize the relative importance, in my opinion, of motor symptoms versus non-motor symptoms. What I mean by this is the tip of the iceberg, the piece that you can see visually above the level of the water, are the motor symptoms. So that is the tremor. You can see that. The stiffness, the slowness, the trouble with walking. Below the surface are all the symptoms that we can't see. And these are considerably greater and make up a considerable bigger chunk of the disease. And I argue that it contributes much more significantly to quality of life. So what's beneath the surface? This. Here's just a sampling. Depression, constipation, anosmia or loss of sense of smell, bladder problems, trouble with weight loss, trouble with speech and swallowing. We call that hypophonia and dysphagia. Blepharitis, dry eye or eye irritation, shoulder pain, trouble with cognitive function or dementia, dystonia. We'll talk a lot about dystonia and muscle cramping, psychosis, sleep problems, sexual dysfunction, orthostatic hypotension. You heard that phrase earlier, which is problems with maintaining blood pressure. So all of these are symptoms that you really can't see on the surface and might even be attributed to other things. You may think, oh, well, I'm, depressed because I have a diagnosis or I have a lot of stress in my life. But the truth is these all are a constellation. They go together, and they are all a part of Parkinson's disease. It was also mentioned earlier that a constellation of these symptoms often occur years and years before diagnosis, maybe even 15 years or 20 years before people say they have experienced constipation, or they've acted out their dreams, they've had trouble with their sleep, or they've had some difficulty with cognition. These symptoms can often predate, and we call that the premotor phase. It's important to identify these premotor phase because if we can somehow target patients early and recognize these patterns, we can start therapies early. And when we get to a cure, we'll be able to administer that even before the diagnosis. Okay, mood. Let's start with mood disorders. I put this first because this is really, I think, one of the biggest contributors to quality of life. Depression and anxiety affect 50 to 75% of patients with Parkinson's disease. And while on the one hand, people may think, well, it's a lot to handle with a diagnosis and with all the stress and debility that comes with the disease, but it's actually more than that. We think that there's an underlying neuroanatomical degeneration that starts even before the diagnosis, before you even knew there was a diagnosis. And that has been correlated with PET scan studies. So it's challenging for clinicians and even for family members to identify mood disturbances. Sometimes symptoms of depression overlap with some symptoms of Parkinson's. So things like a lack of facial expression or moving slow, is that depression or is that Parkinson's? However, if the feelings of sadness and the feelings of despair are pervasive, more so than once in a while, then it's definitely something to discuss. I really appreciated the discussions that took place earlier regarding all of the behavioral and lifestyle strategies that we can use to try and manage mood symptoms like depression and anxiety. And I think it's very important and often underestimated how powerful those things can be, like maintaining social interaction and maintaining good sleep. What I just wanted to do here is demonstrate for you that with regard to the pharmacologic agents that are available, we have many different categories. So if you haven't done well with one category, it may be worthwhile to look into potentially a medication from a different category. The first one being the selective serotonin reuptake inhibitors, SSRIs for short. The next being the serotonin norepinephrine reuptake inhibitors, or SNRIs for short. You can see the names of these medications listed there. If you have tried medications in the serotonin category, perhaps trying one that affects a different neurotransmitter might be a good idea. Next, we have one single agent in the norepinephrine dopamine category, and that's bupropion, or Wellbutrin. Some of the older tricyclic antidepressants used to be more popular before these newer ones came out. Those include amitriptyline and nortriptyline. We don't use them as much anymore because the side effect profile is not as attractive, and also the efficacy pales in comparison to the others. I must point out, this is a question that has come up frequently, and I think it's important to point out this potential for serotonin syndrome. Any of the antidepressants, any of those pharmacological agents do have the potential for interacting with some of the Parkinson medications that you take for your motor symptoms, in particular the monoamine oxidase inhibitors. The common names for those would be rasagiline or selegiline. So it's important when you first start taking either of those together that we monitor closely for new symptoms that you didn't have before. It's very important for you to have a close contact with your physician to be aware if any of these things happen. Next, let's move on to dry eyes, blepharitis. Blepharitis actually is representing a chronic condition. In fact, people have this symptom before the diagnosis of Parkinson's. It's a chronic eyelid inflammation, and there's a lot of redness in the conjunctiva, the covering of the eyelids, and that sets up a milieu that's very easy for bacteria to grow on. And the reason why everyone has this problem is because of the decreased eye blink. So when the eyes aren't blinking as much, you have decreased lubrication there, and this can be very, very uncomfortable. What I recommend is trying high-viscosity lubricant eye drops at bedtime. Common one on the market is called Systane. And Systane at bedtime, the gel, the high viscosity will stay in the eye and won't just run out like regular eye drops, and can provide some relief overnight. Okay, shoulder pain. It's often underestimated what kind of connection shoulder pain has to Parkinson's. And it's so much so that, again, this is another symptom that presents prior to the diagnosis of Parkinson's. Typically, the shoulder pain is unilateral. And if you had to guess which side, I'm sure you can imagine it's the side where there's more Parkinson's symptoms. So stiffness and slowness, what we call bradykinesia, leads to decreased arm swing while walking. And that eventually leads to immobility and subsequent shoulder dysfunction and discomfort. It's basically a setup. So it doesn't directly cause these things, but it produces an environment where you can be much more susceptible to things like bursitis, tendinitis, frozen shoulder, and even rotator cuff injury. So for this reason, physical therapy intervention early is important, as well as the use of big arms, what I call exaggerating the arm swing while walking. Muscle cramping, what we call dystonia, is a hallmark. This is important to recognize because we have good treatments. So if these cause a lot of pain. So if we can identify these and provide relief, that's a huge boost to quality of life. The muscle cramping has two causes. It can be unrelated to treatment, or you can have muscle cramping that is related to the medications. Though the one that is unrelated to treatment usually has to do with low dopamine levels. Typically involves the foot for some reason. We're not really sure why, but the foot, and not usually one side, the side where you have the worst Parkinson's, will have a tendency to turn down and in, and the toes like to curl. Very, very uncomfortable. And needless to say, that impairs gait, impairs balance, and impairs the ability to wear proper shoes. Plenty of other muscles can be affected, but that's one of the more common ones, and we treat that very directly with localized botulinum toxin injections or Botox. Medications also help, but my practice is that I don't like to increase the medications for one symptom. If that can be addressed in another way, that's much more helpful overall. And then next, it can be related to therapy. Sometimes when the medications are kicking in or they're wearing off, people say that they have more of a chance for having muscle cramping. Sleep is such a big deal. I often joke with my patients that Parkinson's disease is just another sleep disorder. There's not one person who has fully normal, restful sleep with a diagnosis of PD, and it can be any sort of sleep problem. The one that gains the most notoriety, I think, is this one, REM behavior disorder. So I'll tell you a little bit about that first. Rapid eye movement sleep behavior disorder is a type of parasomnia in which you have vivid dreams and dream reenactment behavior during REM sleep. So it turns out that the area of the brain that controls sleep is right next to the area of the brain that is involved in neurodegeneration during Parkinson's. So that explains why sometimes people get this symptom even before they have a diagnosis. The reason why this is not something that we like to ignore is because if you are reenacting dreams at night, if you're pretty much awake during during dream stage, you are not getting restful sleep. So the quality of your sleep declines dramatically. And if you're in bed for 8 hours, maybe you're really only having effective sleep for a fraction of that. And you can have chronic sleep deprivation and chronic daytime fatigue. When you're chronically sleep deprived, motor symptoms aren't going to do so well either. So another sequela is physical injury. Some of the dream reenactment behavior could be quite dangerous. You can hurt yourself or your bed partner. So it's important to identify and to manage. The two agents that we use for management of REM behavior disorder are over-the-counter melatonin, up to 10 milligrams at bedtime. If that doesn't work, a long-acting benzodiazepine such as clonazepam. This is a little bit of a tricky one. There's a lot of side effects to sedating medications, so we want to make sure that this is used safely and carefully. Other types of sleep disturbances could be sleep fragmentation. This is a very common one. This is the situation where you wake up repeatedly at night for no reason. This is, could be for the bathroom, but it's often for no reason at all. And we treat similarly with the same type of medications, both the melatonin and the clonazepam at low doses. Insomnia is a situation where there's trouble falling asleep, but sleep maintenance or staying asleep is okay. In those cases, you can use mild sedatives. I'm very, very conservative personally, so I don't like using sedatives in my patients. But sometimes these can be helpful, those that I've listed there, none of which are FDA approved specifically for Parkinson's. Obstructive sleep apnea. This is a situation where there's disordered sleep breathing during sleep, and this is treated by continuous positive airway pressure, also known as CPAP, that's wearing a mask, or even BiPAP. Restless leg syndrome, periodic limb movements of sleep, all of these are diagnosed with the use of a sleep study. So sleep study is an overnight test where they can really monitor brainwave activity, leg activity, breathing, oxygenation, blood pressure, etc. Also known as formal nocturnal polysomnography. What's the end result? The end result of all of these are excessive daytime sleepiness or fatigue. So it's really important to identify because, like I said, these things will affect motor symptoms. You heard earlier about sleep hygiene. I'll just repeat that we really do want, and daytime sleep restriction. That's when we try and minimize naps as much as possible. It seems counterintuitive because you're so exhausted during the daytime that you feel the urge to take a nap, but really restricting that as best you can does serve your nighttime sleep better. Also, fixing a bedtime and wakening time, avoiding alcohol, caffeine, or heavy foods right before bedtime, and restricting your bed for sleeping. There is a stimulant that some patients use. Again, I'm less apt to prescribe this for my patients because I feel like it's a little bit of a Band-Aid, but it's a stimulant. So if the daytime fatigue is so excessive and improving the nighttime sleep doesn't seem to be working, there are stimulants available, one of which is called modafinil or Provigil. Again, it's not FDA approved for the use in Parkinson's, but in the right patient it could be helpful. Okay, you've heard a lot so far about constipation. I can't underscore the importance of this. It really is pretty universal. I don't think there's anyone who is not affected to some degree because it's one of the earliest signs of autonomic dysfunction. In fact, Mr. James Parkinson, originally discussed constipation in his 1817 essay entitled The Shaking Palsy. So it has been recognized that it goes hand in hand with Parkinson's for many, many years. So stools become less frequent, difficult to pass, and there's delayed gastric emptying and slowed intestinal transit time. In fact, pathological studies post-mortem do show that the same type of brain changes, including Lewy bodies, are found not only in the brain but also in the intestine as well. So we manage constipation first by optimizing hydration, having a well-balanced high-fiber diet, as you heard earlier, regular exercise. The AAN has a practice parameter put out, that's the American Academy of Neurology, that Miralax daily is safe for long-term use in Parkinson's. Bladder dysfunction. Bladder the problems can take two forms. The bladder can be overactive or it can be underactive. Most people have overactive bladder. That's a situation where there's abnormal central control of the urinary sphincter. You have symptoms like urgency, frequency, incontinence, and there's several medications that are on the market for this, but I really caution safety. Having to get up so many times at night to use the bathroom is a falls risk. So keeping a commode close by or keeping a urinal close by is probably safer. Urinary retention is the opposite situation. Interestingly, that's a situation where you have incomplete bladder emptying. So the bladder isn't contracting enough. And that is a setup for recurrent urinary tract infection. So that's also very important to identify and treat. Speech. We have a lot of interventions available for speech. Problems with speech could be in terms of enunciation as well as producing volume. The imprecise articulation and the low volume lead to things like social isolation and withdrawal. If you don't feel like having to hear over and over again, what is it? What did you say? Then the chances are you will be less apt to participate in social activities. So it's really important for me and my patients to get involved in speech therapy early. Speech therapy can take many forms. The one I would like to highlight here is the Lee Silverman voice treatment. Perhaps some of you have participated, also known as LSVT loud. This is the goal of LSVT loud is to think loud. And if you think loud, you'll speak loud. It's a systematic hierarchy of exercises. These exercises stimulate the laryngeal muscles and the speech mechanism. It really works, but it's intense, and you have to stick with it. So sometimes we do a modified version of this if the program is too intensive. Along with speech comes dysphagia, also known as trouble swallowing. You might find it interesting that I put drooling here, but I would like to point out that they are drooling is has direct relationship with trouble swallowing. So contrary to popular belief, drooling does not occur from too much saliva being produced. Drooling is actually a result of decreased swallow. So the saliva that's normally being produced kind of pools. And it pulls in the mouth because the swallowing is not occurring as frequently. And then you couple that, for example, with a forward flex posture, and it's going to escape. So it's socially embarrassing, but it is not a dangerous symptom. And there's some medications out there that try and dry out the mouth. I don't recommend them. They have a lot of side effects, particularly in an elderly population. So avoid them if you can. There's sometimes targeted Botox injections into the salivary glands that can be helpful too. About 50 to 80% of patients have difficulty swallowing. We can do a swallow study, and if we do a swallow study on everybody, it would turn out that about 90 to 100% of patients might have some abnormalities. And the reason why it's important to identify this is because it's a setup for aspiration risk. Aspiration is when food or drink goes down the wrong pipe. And that's dangerous because we don't want any pneumonias. But it's often, we have to treat it the same way that we treat the hypophonia or the soft speech and the speech articulation with speech therapy. Some of the techniques that a speech therapist might use are listed here. Some of the swallow techniques that you may have heard of if you go to speech therapy are second swallows, chin tucks, use of straws, and increasing your food consistency. Softer foods are swallowed much more consistently, as well as thickening liquids. Along with the swallow and kind of in the same realm of the GI tract, we have nausea. Nausea can be a medication side effect, but it can also be due to the constipation and the generalized slowing of the GI tract. So if it has to do with the medications, I recommend taking the medications, particularly taking something like carbidopa, levodopa, with a little extra carbidopa. Carbidopa is the element that is preventing the levodopa from working on the gut. And so more of it will go to the brain. If you have additional carbidopa, the chances are you will be able to tolerate the medication a little bit better. The trade name for that is called low-dosin. Finally, you can manage constipation as well as have smaller, more frequent meals, and that should improve the nausea and bloating symptom as well. Okay, next we have cognition. Cognition was discussed quite well previously. I really do want to underscore the importance of being socially involved for maintaining cognition. Isolation is probably the equivalent of inactivity with regard to the physical symptoms. So for our physical symptoms, if we want to do better, we exercise. For cognition, if we want our cognitive and thinking functions to be as strong as possible, we get involved, we socialize, we get out of the house. These are the things that are associated most strongly with patients who have less decline in their ability to think, remember, have good judgment, language function, visuospatial function, etc. Some of the medications that are used in more advanced cases, and I would only use these medications not in an early stage patient, but acetylcholinesterase inhibitors, some of these you may have heard of. There's only one actually that's actually FDA approved for Parkinson's disease dementia, and that's the rivastigmine, also known as Exelon. You may have heard of donepezil or Aricept, which is very commonly used in Alzheimer's disease, but we use all the time in Parkinson's. It's quite effective. Memantine or Namenda, that's another one. Some of the medications and the disease itself contribute to this symptom. This is a difficult one, and I would like to tell you about some of the new agents coming up in the pipeline to treat Parkinson's-related psychosis. That means hallucinations, paranoia. The hallucinations, by the way, are typically visual, less auditory. Paranoia is a very difficult symptom that makes caretaking a challenge sometimes. There are no medicines out there specifically FDA approved for the type of psychosis that accompanies Parkinson's disease. In fact, a lot of the antipsychotics that are used in other psychiatric conditions are contraindicated in Parkinson's because they will worsen motor symptoms. But there are two so far that we can get presently, and those are clozapine and quetiapine. Clozapine and quetiapine are both very effective. You'll have to talk to your physician about which is more appropriate for you. But I want to point out a new one that's exciting, and that is pimavanserin. This is not yet available in the United States, but I want to tell you about it to give you to share my excitement too. This is poised to become the first drug FDA approved in the United States for Parkinson's disease psychosis. What's exciting about it is a medication that acts via the serotonin pathways instead of the dopamine pathways. All the other medications and antipsychotics are all dopamine related, hence the reason why it interacts with our motor symptoms. This one is not. This one is serotonin. So, and it also has a superior safety profile compared to other antipsychotics. So I am definitely waiting for this one. Okay, orthostatic hypotension, you heard a bit about this earlier. This is when you have a sudden drop in blood pressure when you stand up. And the type of symptoms that you may have is lightheadedness, feeling as if you're going to pass out. This can be a feature early, or it can be a feature of more advanced Parkinson's, or even some of the atypical Parkinsonian syndromes, like multiple system atrophy. The first thing to do is employ some of these behavioral strategies to try and raise your blood pressure. I recommend increasing your water and salt intake. Dr. Thacker mentioned earlier about salt tablets, for example, but even just liberalizing the amount of salt in your diet can be helpful. I tell patients that 99% of the population in the United States has to have a low salt diet. You are in the 1% that can actually have more salt in your diet because it helps to raise blood pressure. Rising slowly is really important. Compression stockings, particularly the compression stockings that go up thigh high, they're very difficult to put on. I know that. In fact, if they were easy to put on, they wouldn't work. They really have to try and shuttle the blood up towards the brain where we want it. Having small, frequent meals is helpful for blood pressure, avoiding hot showers or baths, and as you heard earlier, raising the head of the bed. Medications. We have two that you can get now, and then I'll talk about another one that's coming up in the pipeline. Midodrine and fludrocortisone. And actually, I think I'll talk about the new research in a new medication in a little bit. But what I'd like to do next is move on to improvements in non-invasive therapies. Okay, so this segment I've divided into 3 parts: oral medications, exercise, and diet. I promise the exercise and diet part will be very succinct because you've heard plenty about that already. But the oral medications, I think I get a lot of questions about what new medications are out there, what kind of clinical trials can I get involved in. So there's more out there than I will discuss today, but I'll just highlight a few. All right, IPX066. It's not a very catchy name, but it doesn't have a name yet. This is actually a drug that's still not available. It's an oral extended release formulation of carbidopa-levodopa. It is currently in phase 3 trials. And what it is it's basically a tablet made up of carbidopa-levodopa-filled microbeads. And they're designed to have very quick onset of action, but then also dissolve at various rates in the small bowel. How great would that be, considering how short and how frustrating a regular release Sinemet is, taking effectiveness and then wearing off, and taking effectiveness and wearing off. If we could really get a medication that could be longer acting version of Sinemet, this would be great. It is designed to provide rapid absorption and clinical effect, as well as to sustain therapeutic levodopa levels for longer periods. Here's a graph from the investigation, and even though it's not yet FDA approved, you can see from this graph the curve all the way on the bottom is regular Sinemet. The curve in the middle is the effectiveness of our conventional old-fashioned Sinemet CR, which is not as controlled release as we'd like it to be. And the curve all the way on the top is IPX066, which should improve off time by up to 1.25 hours per day compared to regular Sinemet. Okay, next medication in the being studied right now, this is also coming down the pipeline, is very exciting, extended release formulation of amantadine. You heard about amantadine earlier as a treatment for dyskinesias. Dyskinesias, I'll remind you, are the restless, fidgety extra movements that you can develop in Parkinson's. This is an extended release formulation, so it's only once before bedtime. The features is that it's more convenient, it's just at bedtime, easier to comply with, and it should achieve its maximum effectiveness around midday, which is when dyskinesias are expected to be their worst, and supposed to have the lowest concentrations in the evening, potentially reducing the negative impact of amantadine on sleep. Droxidopa. This is the one I promised I'd talk about with regard to orthostatic hypotension. So this is a clinical study of patients with symptomatic orthostatic hypotension, and it is using a drug that is a prodrug of norepinephrine. So there's many patients who are eligible for this study, not just with Parkinson's, but with multiple system atrophy and other conditions where you may experience a dramatic drop in blood pressure upon standing. And this is a multi-center, multinational, multi-country randomized trial, and we had been actually until a couple of days ago recruiting at UC Davis. I think it's just being paused right now, but we'll give you more information as I get it. Next, this is not in the pipeline. Nupro, or the transdermal rotigotine patch, may be well known to most of you, but I wanted to just include it here because I know that some patients are not familiar with the transdermal formulation. So we're very lucky to have Nupro back, very, very excited. It was kind of off the market for a couple years. It's a transdermal skin patch. So it's a form of dopamine agonist, so same kind of category as medications like Pramipexole or Ropinirole, but it is not by pill, so it's not by mouth. That's nice if you have trouble swallowing. But also, the patch provides much more continuous, long-acting delivery compared to pills. Some people have local skin irritations from the patch. They recommend applying the patch in several different areas to try and avoid that. As far as other side effects go, they're similar to their other dopamine agonists, things like leg swelling, nausea. Maybe the patch, some people say, is associated with less impulse control issues than other agonists. exercise. I have one slide, I promise. I knew that this would be covered so well throughout the course of your morning. I didn't want to belabor it, but I also would never leave this out because I believe so strongly that this is a critical component. It is non-negotiable. My patients know that. I will not accept zero exercise in my clinic. The components of a good daily regimen should include stretching as well as conditioning exercises. I want to put a plug there in terms of conditioning exercise for the www.danceforparkinsons.org. I know a lot of my patients participate. It's very enjoyable as a social activity as well as an exercise that has shown great effects in Parkinson's. Incidentally, it's the tango that has been shown to have the most neuroprotective effect. Physical therapy, you've heard a lot about LSVT big, I mentioned earlier, with big arms and big legs. Very, very helpful. Not only does this improve symptoms of gait, but also it decreases falls and slows disease progression. I don't think I can say this enough times. Exercise slows down progression of Parkinson's. And diet. One slide on this too. I'll just point out a couple of important elements about levodopa absorption and diet. So it's important sometimes to modify the protein intake because levodopa competes with protein for absorption. So if you notice that your medications are not working as well around meal times, it might be useful to have meals during, not when you're taking the medications. There's a new levodopa prodrug that's in the pipeline called XP212179, and that is a medication. It's a formulation of levodopa that's absorbed in a different part of the intestine, and it's most of the Sinemet that you take now is absorbed during a very small part of the proximal small intestine, and this new study drug is absorbed throughout the intestine. So much more chance that you'll get a good effect from your Sinemet. So the longer absorption period gives this prodrug potential to provide levodopa in a more continuous way. All right, great. We are now entering a very exciting area. This is our improvements in invasive therapies. I'm very excited about these improvements we have in invasive therapies. Now, by nature, or I guess I should say by definition, if we're talking about surgical or invasive therapies, we're talking about a later stage in Parkinson's. We always like to try all of the above that I just discussed first before we go on to anything invasive. Why? Because the invasive procedures are just more fraught with risks from the procedure itself, risks from hardware, et cetera. So we are talking about more advanced stages of Parkinson's right now. The biggest problems that we're fraught with when we have more advanced Parkinson's is motor fluctuations. That means the medicines don't last as long, and we experience ups and downs. We take our medicine, it works, maybe we have some side effects at peak dose, like dyskinesias, and then it wears off. And then you take another pill in the same pattern. So patients liken this to a roller coaster. Not a fun one, though, and it's something that has been a target of therapy for a long time. How can we even out this roller coaster, the ups and downs? And that's where these elements come into play. So first, for those of you who are not familiar, DBS stands for deep brain stimulation. This involves the implantation of electrodes deep into the brain where we have areas that control movement, called the basal ganglia. The electrodes are then connected via wires to a pulse generator, also known as a battery, which you have implanted into the chest wall. That is similar to the type of location or that you would have, for example, for a cardiac pacemaker. For this reason, people have even called this therapy a brain pacemaker. But deep brain stimulation is not experimental. This is FDA approved. It is not an experimental, it's not a study, it's not a clinical trial. When you have a very well-selected patient who has medication refractory Parkinson's disease, they may be a good candidate for this surgery. What's important to understand is that only symptoms that respond to levodopa will respond to DBS. So for example, if you think about your symptoms and you think about which of your symptoms get better the best with levodopa, those are precisely the ones that will do well with DBS. The exceptions to this rule would be things like dyskinesias, which by definition are worse with medications. That does improve with DBS, and also medically refractory tremor. As many of you may experience, tremor is probably one of the most difficult symptoms to adequately control with medications. But medication refractory tremor and dyskinesias both respond very well to DBS. Selecting the proper candidate for DBS is essential. So it's important that the patient have idiopathic Parkinson's disease as opposed to the multitude of atypical Parkinsonisms that I mentioned earlier. There can be no dementia or psychosis, and the symptom that's probably treated the best with DBS is motor fluctuations, troublesome ons, offs, tremors, and dyskinesias. Deep brain stimulation improves bradykinesia, rigidity, tremor, gait. Symptoms that it does not improve include speech, thinking, postural stability, and autonomic symptoms and mood. Unless, of course, there's elements to that in which that involve being on large amounts of medications. If you can reduce your medications to some degree as a result of DBS, some of those symptoms may improve too. The benefits are sustained long-term, provided that levodopa responsiveness is also maintained. Presently, we are using 2 targets for Parkinson's disease. Those are the subthalamic nucleus, or STN, as well as the globus pallidus pars interna, also known as the GPI. Some of the features of DBS are its reversibility and programmability. This is really, really key. It's adjustable, fully removable. As the disease progresses, deep brain stimulation can keep up with symptoms because we can adjust the program of stimulation. So, needless to say, deep brain stimulation is not a cure for Parkinson's, but it can keep up with the disease quite well by the various modalities that we have to manipulate. We can manipulate the areas of the electrodes that are active. We can manipulate the size of the electrical field, the shape of it, the frequency of pulses, etc. A lot of patients can decrease their medications after surgery, but not all, and I don't think that should be a goal of the surgery, but it is nice. Usually about 50% of the medications can be decreased. The disadvantages of DBS is that it does require patient commitment. Unfortunately, it's difficult to do in a scenario in which you live in a very rural environment and have no contact with healthcare, because we do need to see you frequently in order to make adjustments to the programming and to monitor you. There can be hardware-related complications. We are implanting external foreign bodies into the brain, so complications resulting from that are possible. And then finally, as I mentioned, it's unfortunately not a cure. Deep brain stimulation has a lot of new research, and it would be impossible to just discuss all of them. I wanted to highlight one area that I'm particularly interested in and excited about, and that's with regard to gait and balance. So as I mentioned before, gait and balance are areas that deep brain stimulation traditionally does not improve. In fact, can even worsen. So if we could find a way that deep brain stimulation could actually improve gait and balance, that would be really amazing. Some of the new research involves different targets. The pedunculopontine nucleus, for example, is one such target that has been implicated in gait imbalance. And we've also trying to find alternate strategies for sending electrical impulses. For example, what if you could just get the electrical impulses when you needed it? What if there was a way to not only stimulate, but also to monitor and to record brain activity? Then we could determine when the brain needed extra impulses and what kind of impulses the brain needs. That really is an exciting area. Some of that work is being done by Dr. Mike Okun at the University of Florida, and he has a theory that we have a give and take between two different areas of the brain, between the brakes and the gas. He thinks the globus pallidus pars interna may be the gas pedal, and the pedunculopontine nucleus, or the PPN, being the brakes. And maybe it's an interplay between those two areas that improves gait and balance in Parkinson's. So really very, very exciting. Duodopa. So duodopa, I've had a lot of questions about duodopa, and I'm happy to be able to hopefully clarify some of that. This kind of came up, I think, as an obvious remedy for a problem that's been going on for years, and that is, how can we get levodopa into the body in a very consistent way without taking pills? Is there some way that we can pump the levodopa directly into our intestines? Yes, now there is. We now have this levodopa-carbidopa intestinal gel, LCIG, that's delivered directly to the proximal jejunum by a tube, and the tube is connected to a portable infusion pump. So what that does is it avoids the erratic gastric emptying and improves intestinal absorption. And if you can get the levodopa in continuously, you won't have ups and downs. You won't have rapid ons and rapids offs. It will just be going in continuously. It improves motor fluctuations, and therefore, if it improves motor fluctuations, it also improves dyskinesias. It reduces off time by about 4 hours per day. Incidentally, DBS has similar numbers. Deep brain stimulation is also thought to reduce off time by a similar amount. This is what it looks like. The duodopa is a small tube inserted into the proximal jejunum, and there's an external port where there's a cassette that holds the Cinemet gel, and it is pumped in continuously. So the pump is programmable, which is also nice. So it's not going in at a rate that cannot be adjusted. It can be adjusted depending on where you are in the disease. And it can be adjusted not only by the physician, but also by the patient as well. It has been in use in Europe for over a decade, and it was approved for use in Canada in April of this year, and should be available in the United States very soon. So I am very, very excited about this. It is prone to some technical problems. Clearly, it's a pump, so pumps can have issues, and it requires a caretaker for the times that the pump is off. Next, we'll talk about subacute apomorphine. Apomorphine is a form of dopamine agonist. In fact, it is the strongest dopamine agonist out there. Just to remind you, dopamine agonist means things like pramipexole or Mirapex, Ropinirole or Requip, Retigotine or Nupro. That's the category called dopamine agonist, and this is the strongest of them all. The medication is injected subcutaneously. That means it goes under the skin. It has an exquisitely rapid onset, which means it works very quickly in 5 minutes, but it also wears off very quickly too. So if we're just going to do one injection, it would be very helpful for rescue. So a situation like freezing, where you might be immobile and you already took your dose of medication and can't wait for it to kick in. It's taking too long. This could be a nice bridge to the medication. The brand name for that is called Apokyn. We also can infuse it continuously, sort of like a diabetic patient who has an insulin pump. If you have the apomorphine, you can implant it and use a subcutaneous pump. This is a very viable option for patients with motor fluctuations. But like I said before, it's a very, very strong dopamine agonist. So therefore has a lot of the dopamine agonist-related side effects like impulse control disorder, psychosis. In fact, it's contraindicated in patients with dementia or psychosis. The nausea, unfortunately, is so severe that it does require pretreatment with antiemetics or anti-nausea medication about 3 to 4 times per day. Right now, it's got a lot of side effects, but it's promising, and it's available only in Europe. Okay, stem cells. This is our very, very exciting. I know there were a lot of questions about stem cells. Stem cells had a really bad rap, I think, in the 90s and 2000s. It was very controversial because of the source of stem cells, which were fetal embryonic tissue. What I'd like to tell you about is new sources that really improve the ability for us to use these stem cells. Stem cells have 2 benefits. Number 1, they allow us to understand Parkinson's disease because it allows us the ability to study Parkinson's in a petri dish. And we can also study and find new drugs to treat it. There's a very important entity called the induced pluripotent stem cell, iPSC, and this is new. This is an amazing technology that just came out in 2007. These use adult cells. They're non-embryonic. They're actual skin cells, typically taken from the forearm, and the technology is now available to take these adult skin cells and reprogram them. I don't do this, but they're reprogrammed into an embryonic state, and that's magic because the embryonic state is a state where that cell can go on and become any cell in the body. Then what we do is try and coax that cell to become a Parkinson's cell or to become a brain cell that's involved in producing dopamine, which are the cells that are affected in Parkinson's. We can test new drugs on these cells. And if they're successful, we can test those drugs in animals and then finally on humans. In addition to studying how Parkinson's works, what is the underlying pathophysiology, and what new drugs can potentially be applied, stem cells also provide the potential for therapy. Replacing neurons that are damaged from Parkinson's with the patient's own stem cells. So these are adult cells from you that are reprogrammed to be cells that can be re-implanted into your brain. Studies are underway to transplant dopamine-producing stem cells into the brains of patients. There's some new delivery systems that can implant these cells directly into the basal ganglia. We know from the early fetal studies and the embryonic stem cell studies that even though a lot of them went awry, a lot of them worked. And so they were on to something. And so we think that one of the reasons why they had such mixed results is fetal stem cells are very tricky and very difficult to control quality, very difficult to control what cells are actually going in. They're prone to tumors. How do we turn them on, shut them off? These cells are different, and I think they hold a lot more promise. I'd like to end by letting you know about our advancements within the realm of support and resources. First and foremost, we have PANC, Parkinson's Association of Northern California. If you don't know these website addresses, we will make them available to you. But PANC is really amazing in terms of the regional support groups that are put on, caregivers lunch groups, the men's group. the annual education seminar. And so it's a gem of a resource that's available locally. I also would like to highlight a new one that I recently learned about called the Brian Grant Foundation. You saw Brian Grant in the documentary, and Brian Grant has really put together a fantastic foundation, briangrant.org. And they put together wellness retreats. If you go on to his website, you'll see a host of exercise videos. He puts together a Powering Forward boot camp, and there's a lot of information on Parkinson's nutrition. He has something called the Parkinson's Plate, healthy eating tips, restaurant trip tips, shake of the month, fast snacks, etc. People ask me often, wow, the internet is full of so much. How do I know what's good information and what's bad information? And I agree, that's a difficult question. The internet, when you go to the internet, there's so much misinformation out there that's very dangerous. But I just wanted to turn your attention to 3 that are legit. These are fantastic websites for additional information. One is the Michael J. Fox Foundation, probably the most comprehensive website out there for everything related to Parkinson's research and getting involved. It's called michaeljfox.org. There's the National Parkinson Foundation, or parkinson.org, and the Parkinson's Disease Foundation, or pdf.org. These have really good information. Finally, how do you get involved? I really encourage. There's so much on the horizon. It's very, very exciting. This is a very exciting time as a Parkinson's specialist, and I hope is an exciting time for somebody who has the disease, where knowing that there's so much coming down the pipeline, there's so much research being done. I hope that you are hopeful, and I also hope that you're inspired to participate, because it is only because of patients like you participating in these trials that we can get this valuable information. The National Institute of Health has a repository of all the trials that are going on across the country. It's clinicaltrials.gov. That's a government site. I encourage you to go on that. Michael J. Fox also has foxtrialfinder.michaeljfox.org, and that's a very, very helpful link as well. If you search for Parkinson's disease, you can even then search by location and find trials in your area. A lot of trials these days are online. They can be by mail. They have questionnaire type studies, virtual testing, or even more involved trials like drug trials or procedure trials. And there's trials in your local academic institutions. We have trials going on at UC Davis. I have the names of some of our clinical trial coordinators on here that I welcome you to contact if you have any further interest. All right. Thank you very much for staying. I appreciate it. Take care.